So our agenda will be to talk about what's working, what's not, and what's needed. And when we talk about what's needed, it's not just a new EHR. We're going to talk about EHR design, but also talk about EHR implementation and then about policies around the EHR implementation. So what's working? Shared information. This is not news to any of you, but it's wonderful to be able to share with our patients information from their electronic health records. So every time we change a medication, our patients get sent home with a new list that's updated, highlighted with the change. And they can share that not only with we can share that not only with the patient, but with their caregivers. As many of you do, we have an electronic portal so that patients have another mechanism for communicating with us. But there are two things I wanted to highlight about what's working that we're doing a little, but I'm really hopeful about it for the future. And one is this idea of virtual consults. So now I can be in the room with a patient and get one of my colleagues on the phone, put him on speakerphone, and he can be reviewing the patient's x-ray while we're having a conversation with the patient in the room and crafting the next steps for that patient. And when that happens, I feel like our care is really good. Then we're really living up to our aspirations. And another thing that I'm pretty excited about is what we've all hoped for, and that's interoperability, sharing information across settings. And I had an experience of this weekend. My husband is also a general internist, and he was on call, and he was admitting a patient who was visiting Dubuque from Boise, Idaho. She was being admitted with chest pain, and she'd had a cardiac workup a few months ago in Boise, and so he thought he was going to be somewhat in the dark about her care until he opened up the electronic health record, and there was all of her information as if she'd been hospitalized in Dubuque. And it turned out that the two hospitals are in the same system, and it really enhanced his ability to care for that patient. So that's what's working. But what's not working? This is an email that I got from a physician in Alaska. I used to be a doctor. Now I'm a typist. And I think in that simple sentence, we wrap up much of what's not working and what's costing our patients and our U.S. healthcare system. So I'd like to unpack that a little bit with 4 studies and an email. So the first, this is the Army Surgeon General testifying to Congress about the top 3 reasons that physicians leave the DoD and that the EHR is within that top 3. This is the RAND study that Jay talked about earlier this morning, which identified that one of the greatest sources of dissatisfaction for physicians of all specialties is the EHR, because too much time for task, too much clerical work, and decreased quality face-to-face time with our patients. This is a study that I was a co-author on, and we identified 5 challenges that are common in primary care practices. And one of those, and the most important, was EHR implementations that push more work to the physician. Work that was previously done by a receptionist, a transcriptionist, a medical records clerk, a billing clerk, a pharmacist, is now the work domain of the physician. And then this study that came out this year in JAMIA that identified that as the number of EHR functions increased, so did physician burnout. So that all those things we were looking forward to in terms of electronic health records, email, order entry, alerts, reminders, communication with our patients and with our colleagues electronically, the more of those functions that were turned on, the more burned out physicians are, and the more likely they are to want to leave their practice. And then here's an email. So when I was asked to give this talk, I sent out to several listservs that I'm on an invitation to give me feedback, give me your thoughts about improvements in EHRs. Well, my inbox was flooded with ideas. And this is from one of my colleagues in the Society of General Internal Medicine. And this is Dr. Gail Sullivan, and she is an award-winning educator at the University of Connecticut. She's the program director of geriatrics there. And she is a leader in medicine. And her email reflects the content and the tenor of the other emails that I had received. The EHR has been devastating. We can no longer teach medical students due to the time it takes to enter primarily useless data. I now see 4 patients per half day, whereas I used to see 8. And I actually spend less face time with these fewer patients. Working in clinic has become so painful that I have decided to leave my beloved patients. Unbearable to think about. She went on to delineate some of the issues that were leading to this frame of mind. 18 clicks to carry out one function. EHRs that are so cluttered with non-information that it's hard to review the past, and so I don't always, and then feel guilty about not living up to aspirations for better care. And she concluded by saying, I used to leave the clinic at 6:30 every night and feel really good about the care I had given. Now I spend several hours longer at work and have work left to do on the weekend and don't feel as good about the care. So, what's needed? And again, we're going to be thinking about what's needed not only in the design of the electronic health record, but what's needed at the institutional implementation level and what's needed at the policies that surround that EHR and implementation. So first, at the design level, better information display. We need clear, concise, and display with reduced clutter to reduce the cognitive workload of interacting with this information tool. The term high fiber notes has been coined, and I'm sure any of you who get these 6-page notes and you can't figure out, well, what was the patient's story and what did the physician think? You understand that idea that currently we have a lot of noise to signal. We want a higher signal to noise ratio. So here's one example. This is the medication list in my hospital's electronic health record, and it is a snow screen. It's just cluttered font. And it's very difficult to sort out what is this patient's medications, get that handle on it from all this extraneous information. So if you just wanted to know what's the patient's diabetic regimen, it takes a lot of mental effort to do that because the medications are scattered among 2 different pages on the in the electronic health record. And they're not in any order, so the breakfast Humalog is on one page, the lunch is on another, and the dinner is on a third, and they're not in chronological order. So if we wanted to unclutter, well, it might look like this, and it's much easier for the clinician to very rapidly digest what the medications are. We've got the diabetic medications clustered together, and we're using symbols, and we're alleviating all the unnecessary information. The cardiovascular medications, the PRNs. This is the vitamin K order set in my hospital's electronic health record. I defy any of you to figure out how to get through this, to identify which line is going with which, and it is very representative of the order sets and the poor user interface. This is a safety issue. So, the second big improvement in design is time. Too many clicks, too much time. So we need fewer clicks, scrolls, and screen pages to do the work. So as one example, in my organization, it takes 21 clicks, 8 scrolls, 5 screens to compose the billing invoice, which has become, in my institution, as in most, a physician function. That takes nearly a minute to do. And you might say, well, what's a minute? But it's a minute on top of hundreds of tasks that each used to take a few seconds that are now taking a minute. And that matters because time really is quality. It's the time to listen to the patient, to hear their story, to read those nonverbal cues. It's access to care, it's safety. So the third recommendation is to align electronic workflows with the clinical workflow, instead of having rigid electronic workflows that you expect the clinician to modify to. Fourth, have a patient-centric design. I think currently most of our electronic health records are billing-centric, and we get these high-fiber notes that don't tell us what we really need to know. So here's a note that I got just this week from our emergency room. The patient presents with palpitations. The onset was just prior to arrival. The course duration of symptoms is resolved. Character of symptoms skipping beats. The degree at present is none. The exacerbating factors is none. Risk factors consist of none. Prior episodes, none. Therapy, none. Associated symptoms, near syncope. This is how the notes from our emergency room come every single day. Where is the patient's story? Where is the physician's thought? And I think the patient's story really matters. If we continue to take our history on a billing template, if we continue to record the patient's story as a series of drop-down boxes, we will start to look at our patients as a series of drop-down boxes, and they become generic to us. instead of unique individuals. And at that, we've lost the soul of medicine. So here's a hopeful note. This is a project going on at the VA in Madison, Wisconsin, where volunteers will spend an hour with a patient recording their life story and condensing that down into something that the healthcare professionals can access and read in the chart, so that the patient does become more than just a series of drop-down boxes. So other things around patient-centeredness in the design include, as many of your records have, the ability to have a picture of the patient whenever you open that. So you can bring to mind who that patient is more easily for between visit care. To have a place for social notes, not just a series of drop-down boxes in the social history, but actually, what about this patient? Who is this patient? What makes them tick? And then I think we really need to change our design to move away from being visit-centric to being longitudinal. The visit note drives billing, but it's the longitudinal care that really drives quality. So fifth, design for teamwork. I think our rhetoric and our aspirations are toward a team-based model of care, but our tools and our policies are really thwarting that. They're really based on the solo model still. So in our practice over the last 2 years, my husband and I have developed what we call the collaborative care model. It is the best model of care we have ever given. The nurse stays with the patient from the beginning to the end of the appointment. And although it is the best model we have ever given, we are nearly brought to our knees by the malalignment of technology and policy to this model. So a few things for teamwork. If we were to design for teamwork, the electronic health record would allow multiple users to be in the record at the same time, or allow seamless transitions from one person to the next. In our record, it takes 1.5 minutes to move from the nurse to myself. We can't be going back and forth in a collaborative way in the care of a patient with that. I recommend that we have a team login. I also recommend that we recognize that not every single element of care needs to loop through the physician. And not every single element of care needs to be looping through the eye of the needle of the electronic health record. So at the institutional level, I think it's time for an upgrade in terms of the hardware. So here's data that, this is from the University of Utah, but the data itself is from Health Partners in Minneapolis, that a printer in every room saves 20 minutes of physician time per day. And I have seen physicians who type up the after-visit summary, hit print, they run down the hall, around the corner, down the hall again to the printer, pick it up, down the hall, around the corner, back to the room. We don't need to have that. A printer in every room saves that kind of time. Flow stations, where the physician and the nurse or medical assistant sit next to each other, that's been shown to save 30 minutes of physician time per day. Large monitor, where you can see a larger swath of the patient's data in one scene. That saves 20 minutes of physician time per day. At the institutional level, I also recommend that we update the staffing model. This is a patient who wrote on a blog, "I would prefer data entry be the responsibility of someone other than the physician. On a recent visit to a new doctor, I believe we made eye contact twice, upon her arriving and leaving." Dr. Kevin Hopkins at the Cleveland Clinic has devised a scribing model, and you can see here he's able to give undivided attention to his patient, while his medical assistant is doing some important work of record keeping. Another physician in this model reports, "I get to look at my patients and talk with them again. We're reconnecting. Our patient satisfaction numbers are up. Our quality metrics have improved. Our nurses are contributing more. And I am going home an hour earlier to be with my family." So at the institutional level, the next item is to avoid compliance creep. I think it's a myth that we can have a perfect audit trail, a watertight audit trail. And if that in fact, that kind of audit trail is unattainable, and to seek after that isn't the goal. It's quality of care that's the goal. And I think we haven't really dealt with the costs of anticipating that every single clinical act and every single clinical thought will be converted into digital data, and the unintended consequences around that. So in terms of performance measures for policymakers, turning now to policymakers, related is the idea of, I think we need to get away from this expectation that we can devise a performance measure for every single aspect of care, because there are unintended consequences at the front lines of being the person responsible for that kind of data entry. And then I'd like to share with you an example around avoiding regulatory micromanagement. So in our practice, we use what's called a visit planner to arrange the next step for the patient. It's a paper checklist, and very easily I can orchestrate a very complex next steps for the patient. I might say return to clinic 3 months with FBS-A1C and this kind of referral and this other order. And I check it off. The patient takes it to the receptionist, who schedules the next appointment and then records the lab or the x-ray that's requested. That takes me 3 seconds per patient to do. It takes 2 minutes per patient to do that work in terms of the typing. It works very well in our organization to entrust that work to the member of our team, the receptionist, who's capable of doing that. But Meaningful Use Stage 2 disallows that process. There's a financial penalty for that process. Meaningful Use Stage 2 has been interpreted by many institutions to mean the physician is doing that. And I feel that that's a form of micromanagement that has unintended consequences. So I'd like to close by sharing with you a metaphor that's really been meaningful to me over the last few years. It's knights, knaves, and pawns. And I think we need to build the socio-technical policy environment that approaches physicians and other healthcare professionals as knights to be empowered in their service of patients, more as knights and less as knaves not to be trusted or pawns to be manipulated. Because I think the more the environment treats our professionals as knaves and pawns, the more knave and pawn-like behavior we will elicit. So take-home messages. In the first decade of EHRs, I think they've been both a blessing and a burden. I don't think we'd ever go back, but we need to continue to move forward. The work is not yet finished. And it's not just the EHR. It's the EHR, it's the implementation, it's the policies around it. And so some final recommendations. First, that the new technology requires a new delivery model. The notion of the doctor as a secretary is not a winning proposition. We need a new model of support staff. And then the idea that we need our policies and our technologies to align with this vision of team-based care. And so the final quote I want to leave you with is from Dr. Paul Grundy, who is the president of the Patient-Centered Primary Care Collaborative. And what he has said is, what patients want is that deep relationship with a healer. That is the foundation upon which medical care should be built. And I think our job is to create the environment that facilitates that. So thank you.
Thank you very much, Dr. Sinsky. We have a few minutes for questions. If people have any questions for Dr. Sinsky? Yes, sir.
On these 75 doctors, I just wanted to reinforce the scribe concept, because we have one doctor that does that. He's been doing it for a long time. And he is much more efficient and much more productive and has much higher personal satisfaction. He just moved from a solo office into a group with other people. He finishes earlier. He's a happier guy. And we're going to definitely consider taking the scribe concept out. And as an interim step to that, I read actually a small blurb in the AMA News when it was still out about putting a computer screen in your room. I have a 40-inch monitor where my view boxes used to be. And when I look at the EHR, my patients can see what I'm doing at the same time, increase satisfaction there. So we definitely need to adapt that type of concept.
Other questions? Yes.
I agree with a lot what you have to say, but some of those that complained the most about the EMR were probably the ones that complained the most of the paper chart data. And you need to aggregate some of that behavior and try to change that as well.
So I think you're right. If you've got inefficient processes in the paper world, you can certainly bring them on into the electronic world. But I also do believe that if 1 out of every 2 U.S. physicians is experiencing some sign of burnout, we really have a systematic problem, and we have an infrastructure problem that we need to address to let everyone feel good at the end of the day at 6 o'clock rather than at 8.
Other questions? Yes, sir, in the back.
Sterling Ransom, President of the Medical Society of Virginia. I really thought your talk was fantastic. A couple of points I just wanted to make. First off, I've been a medical scribe for close to 9 years now. I can tell you what a freeing experience it was, and we have to talk to any of you about it. The biggest problem for me was losing that control. I'm a family physician. When I thought some of the most important things I got from the patient was sitting down talking about their aunt who had recently passed away or things like that. And those aren't things that fit into the digital, rigid nature of the EMR. And I wasn't doing it when I was typing. I was putting in as basic a note as I could because my 2 fingers could not keep up with my brain. Once I switched over to a scribe model, a lot of that stuff was incorporated into my EMR notes. They became much better, much more telling when you can get around the fiber of the note. The second thing was your mention of a photograph. We had Centricity, which is being sundown next year, I believe. So we're going to have to find a new one. But I was told for years we couldn't do a photo because it took up too much memory in our servers. I can tell you we've been doing it now for about 2 years, and the photo helps an incredible amount. I've got one name with 3 different patients with the same name. 2 of those patients have the same middle initial that are born within a year of one another. So trying to figure out which one I'm talking about on the phone or if I give a note, the photo helps a lot. And the most telling thing that ever happened was about 2 years ago, I had a patient who was markedly depressed who came into the office, and the picture was taken of her at the front when she walked in to see me for the first time. About 3 months later, after 3 months of Effexor, I looked at her in the exam room and looked at her picture in the EMR and said, oh, come here, I want to show you something, and showed her that picture of her flat affect and looked at her, then I said, look at yourself now versus then, and tell me how this worked. It was absolutely remarkable for her to just see what she looked like, and that helped a lot. And lastly, I just want to comment on the rigidity of the EMR and sometimes some hospital administrators. I talked with a patient, excuse me, with a physician about 2 weeks ago who they just were transforming into a new EMR. He was driving home from the hospital, got a call from a nurse, and he said, I'd like you to initiate this treatment regimen. She said, we cannot do that under orders from the hospital. You have to do that via computer while he's in his car 15 minutes away from home. So I think we need to figure out a way to induce some flexibility into some of these programs and the way that we use them. Because how are you going to get the best patient care if you're in your car and how are you going to type that note in when the nursing staff won't take phone notes?
So I think those are great points. And first of all, I'd like to invite anyone who's had any experience with collaborative documentation to give me your cards, give me some way to communicate with you because I'd like to pursue that. Secondly, one of your organizations, and I'll leave it quiet as to which one, requires that when the physician comes out of the office, the exam room, and asks the nurse to do an ear wash, they have to first go to the computer and put in an order. And I think we've lost our way. We have lost our way when a physician can't give an order over the phone, and we've lost our way when we need to have an order, an electronic trail for the ear wash.
Other questions? Does anybody need an ear wash? No. So, all right. Guess everybody was listening. Okay, good.